Hello, everyone. Can you hear me?
Yes.
All right. So my name is Parth Shah. I'm second year at Wellstar Kennestone, working with Dr. Rao. This is a case report, and it's regarding a patient who was a post-op kidney transplant. He had it last in 2002, and he's been on the usual regimen of tacrolimus, mycophenolate, along with prednisone. And he was doing well up until August 2020 when he ended up having a cardiology office visit, in which he had a repeat echo done because one of the initial ones prior to that had shown uh, moderate to large amount of pericardial effusion. So it was just a follow up, and that had shown the same thing consistently. So then he was brought in by the cardiologist from the outpatient setting, and the hospitalization course mostly consisted of nephrology on board, reducing initially reducing the dose because the dose of tacrolimus was initially prescribed zero point 0.5, but the patient had taken 1.5 in the morning, 2 in the evening, so it was more than the required amount. Along with that, he ended up having pericardiocentesis done, and that removed about 750 cc's of fluid. They did the testing, as you can see in Table 1, August 2020. Most of the testing was negative. And one thing that most people look at in terms of fluid analysis is whether based on the LICE criteria, whether it's transudative, exudative. But based on what research have shown, in at least in pericardial effusion, doing a using the LICE criteria to test is really non-diagnostic. Only time we can really tell if something is absolutely the cause of pericardial effusion is if there are any malignancies. But in this case, there's no malignant cells, so overall, you can't really get much information from there. Followed up with that, they also did biopsy of the pericardium, and that was also negative. And then eventually, he was put back on the zero point 0.5 twice a day tacrolimus and discharged a few days later, but then came back again with anorexia, fatigue, and other symptoms. We went through a similar workup with the fluid analysis, which, as you can see, is negative. And this time around, they also stopped the medication. The nephrologist stopped the tacrolimus um, uh, with his creatinine improving from 1.5 to 1.3, and baseline is 1.3 to 1.4. So it basically showed that one of the side effects of tacrolimus being nephrotoxic as well. So it could have built up in the system, worsening his status as well. So last in the previous hospitalization in August, they didn't do any further workup, so that's why they in December wanted to get rheumatology on board, since so far everything was negative. Um, so they did all the ANA, which consisted of double-stranded DNA, Sjogren's, the anti-Smith, CRP, ESR, basically ruling out all the Sjogren, the lupus, um, along with the mixed connective tissue, and then any kind of inflammation going on, rheumatoid arthritis, even aldolase associated with the um, dermato and the polymyositis, HIV, TB, all these other markers were all negative as well. So once they went through all of that, they basically pertained that despite having been on tacrolimus since 2002, and that's been at least 18 years that he's been on without any issues, he's that they pertain the pericardial effusion due to tacrolimus toxicity. And in the imaging, as you can see below, it basically, so this imaging wasn't the initial one. The initial imaging had shown large pericardial effusion. This one is more like towards the end, of course, when he had a lowered amount of pericardial effusion, more like trivial. So we just wanted to show that, especially in figure 2, as you can see, the yellow star showing the left ventricle, the red is the left atrium, and then right below that you'll see a little bit, I don't know if you can see the arrow, but the arrow is pointing to the trivial pericardial effusion, which is usually what you can see in this kind of setting. And the overall, I guess discussion and teaching point wise, we wanted to portray in this case is one, to know what side effects are usually associated with tacrolimus, and even its other immunosuppressives as possible, like nephrotoxicity, neurotoxicity can cause infections, even fluid in the belly, ascites, and pleural effusion. But in this case, it was like there have been really rare incidences of having pericardial effusion. Other thing is we wanted to show us the differential diagnosis, things to look at is infection, malignancy, medications, autoimmune history, trauma, all these things have to go through. And in our case, it was more of a diagnosis of exclusion that pericardial effusion was due to the medication use rather than anything else. And since it was because of the medication, then other things you do in terms of that is make sure you either reduce the dose, stop it, and give an alternate medication. And in his case, so he wasn't here. He was mostly followed by Piedmont, but he ended up coming here for these 2 hospitalizations, and then after that was went to Piedmont in Florida. So it was kind of hard to follow up on what happened after, but that's basically to show the association, less likely causation because it's just a one-time or very few incidences of it associated with tacrolimus, but because of diagnosis of exclusion, we think it's more associated with that.
Awesome, thank you again also for a wonderful presentation. We'll open up if anyone has any questions. All right, well, I have a question as always. So I may have missed this, but what is the incidence of tacrolimus-induced pericarditis? It's not something I've heard before, and I'd like to that point.
Sorry, what was that question?
What's the incidence of tacrolimus-induced pericarditis?
Oh, okay, so it's at least it was been around 1 to 2%. They haven't had much studies in terms of tacrolimus, but sirolimus has had a lot of. It has maybe around on average 2 to 12%. That's what I gather from the data that they've tested more with sirolimus because that was mostly given, but tacrolimus has been a lot far less compared to sirolimus.
Awesome, thank you.